tonight is on inflammatory bowel disease, and we'll now hear from Dr. Mark Lust.
Great, thank you. So my name is Mark Lust. I'm a gastroenterologist at St Vincent's Hospital, and I will be trying to cover inflammatory bowel disease, which is an enormous topic in itself. So to get through that in 40 minutes, I'm going to move fairly quickly, but you'll also obviously have access to this talk and these slides to peruse at your leisure. So what I want to cover is just a little bit about the disease itself, its classification, what we know about its epidemiology and pathogenesis, as well as its natural history. But we'll probably focus mostly on its management, going through treatment options, our goals of therapy, and some of the evolving treatment paradigms related to therapy, and then just touch on a few special circumstances related to inflammatory bowel disease at the end. So what are we talking about? We're talking about a group of idiopathic chronic relapsing inflammatory disorders of the gastrointestinal tract. And these can broadly be divided into two main types. Ulcerative colitis, which is characterised by a diffuse mucosal inflammation, which universally involves the rectum but can extend proximally, always in a continuous fashion. It's always limited to the colon. And just remember that its location and extent is not always static and can change over time. Histologically, ulcerative colitis is characterised by inflammation that's confined to the mucosa or submucosa. It's a superficial disease. It's characterised by architectural crypt distortion and inflammation, which can lead to cryptitis and crypt abscesses, and the absence of granulomas. The other main form of inflammatory bowel disease is Crohn's disease, which differs from colitis in that it can be segmental inflammation involving different parts of the bowel with skip lesions, and the inflammation is transmural, so involves the full thickness of the bowel and can affect any part of the gastrointestinal tract, most commonly the distal ileum and proximal colon. And histologically, as I've mentioned, the inflammation is transmural, and the main pathogenic finding that characterises Crohn's disease is the presence of granulomas, which, it must be said, are only present in about 30 to 50% of cases, so an absence of granulomas does not exclude a diagnosis of Crohn's disease. Crohn's disease can present with different phenotypes, from a purely inflammatory phenotype. Sometimes patients will develop deep penetrating ulcers, which leads to fistulization, or submucosal fibrosis, which can lead to stricture formation and obstruction. In terms of its epidemiology, the incidence in Australia is estimated to be around 29 per 100,000, but is increasing. So we think about 1 in 300 people, or about 65,000 Australians, are currently affected by inflammatory bowel disease. It can occur at any age and has a peak age of onset between about 15 and 30 and affects males and females equally. We still don't know what causes inflammatory bowel disease. We know it is usually driven by an abnormal immune response to some form of luminal microbial antigen or some other antigen in a genetically susceptible host, usually after exposure to some form of environmental trigger. What's the evidence for a genetic influence? The prevalence of IBD varies amongst different populations, and the risk is increased amongst first-degree relatives, and there's a greater concordance amongst monozygotic compared to dizygotic twins. And a number of susceptibility genes have been identified, none of which you'll probably really need to know a great deal about, other than perhaps the most commonly described one, which is the NOD2 or CARD15 variant, which is associated with Crohn's disease, and a particular phenotype of Crohn's disease in that it usually results in patients developing more small bowel involvement with a stricturing phenotype at a younger age and a higher risk of requiring surgery. In terms of environmental factors, perhaps the best described is the effect of smoking, which has a detrimental effect on Crohn's disease, but perhaps counterintuitively may actually be protective against ulcerative colitis for mechanisms that are unclear. There is evidence to suggest that prior appendicectomy may protect against ulcerative colitis, and there's some evidence or there's some research looking at specific infective etiologies. One that gained some attention was the role of Mycobacterium paratuberculosis, although this has never been definitively proven. And there probably are influences from diet, certain medication exposure and psychological stress on disease course, but not necessarily as a cause for disease itself. Mucosal immunology is quite a daunting subject, and probably the subject of the whole talk itself. So I won't go through immunology in any great detail with you today, just a single slide to suggest that there may be a couple of defects that lead to inflammation and inflammatory bowel disease. It may be that inflammation is caused by an inappropriate activation of a normally functioning immune system, and that might be triggered by some form of yet to be identified pathogenic organism or a change in gut microflora, or possibly epithelial barrier dysfunction. On the other hand, it may be that it's an inability to down-regulate the immune response in response to a normal microbial antigen, which provokes either an excessive effector T-cell response or an ineffective regulatory T-cell response. In terms of establishing a diagnosis of inflammatory bowel disease, obviously this requires history and examination, with the findings usually dependent on the location, the extent and severity of disease. But most commonly, patients will present with diarrhoea, rectal bleeding if there's colonic involvement, and abdominal pain is a common feature as well. Some patients will present with systemic features such as fever or weight loss. There is no diagnostic laboratory test. We can get some clues from inflammatory markers such as elevations in the CRP, ESR or platelet count, sometimes anemia. Fecal calprotectin is another useful test. This calprotectin is a cytosolic protein that's released by inflammatory cells in the gut. An elevated fecal calprotectin is specific for gut inflammation, so it can be helpful in a patient who's presenting with undifferentiated gastrointestinal symptoms to determine whether there's underlying inflammation or irritable bowel syndrome. And this might sort of select patients that need further investigation, such as colonoscopy. And fecal calprotectin can also be used to monitor patients with established inflammatory bowel disease, to monitor disease course and response to treatment. The gold standard for establishing a diagnosis is obviously colonoscopy and histology, and we may get supplemental information from imaging of the bowel as well. So just a few endoscopic pictures to give you an idea of what we're talking about. This is a normal looking colon, and these are photos from patients with ulcerative colitis of varying degrees. So a patient with mild colitis where you can see some erythema and a loss of the sort of normal underlying vascular pattern, and that can progress to hemorrhagic sort of edematous mucosa with spontaneous bleeding, all the way to deep ulceration and stricturing. In Crohn's disease, patients may just have a few small aphthous ulcers in an otherwise normal looking bowel. You can get sort of larger pleomorphic ulcers, linear snail trail ulcers, or in this very severe case, this is cobblestoning of the mucosa, where you have islands of actual normal large bowel mucosa with intervening areas of deep ulceration. I spoke about the histology earlier, so I won't go through that in any great detail again. We have had some advances in our ability to visualise the small bowel, and this is obviously important in patients with Crohn's disease. Wireless capsule endoscopy allows pictures of the small bowel to be taken as the capsule traverses the small bowel. This does result in some false positives, particularly in patients taking non-steroidal anti-inflammatory drugs who might have some small bowel inflammation and ulceration, and there's limitations in that we can't obtain tissue for histology. It's also an expensive test and is only currently rebated for patients with unexplained iron deficiency anemia. Double balloon enteroscopy allows deeper endoscopic penetration into the small bowel, either from above or from below. But this test has limited availability. It's only available in a few larger tertiary centres done by interventional endoscopists. It's an expensive and timely test, but does allow for diagnostic and therapeutic procedures or intervention. Imaging of the small bowel may be helpful if we're looking to characterise Crohn's disease particularly. We don't do many small bowel follow-throughs anymore. CT enteroclysis and MR enterography can give very good views of the small bowel. MR probably preferred over CT where it's available, only because of less radiation risk involved. But you can see examples here whereby it shows sort of thickening or hyperemia of the bowel wall in a patient with active inflammation. You can see areas of stricturing or narrowing here, which will be a small bowel stricture with some proximal small bowel dilatation. So some of these distinguishing features that allow us to differentiate between Crohn's disease over ulcerative colitis, the presence of perianal disease, which is rare in ulcerative colitis. Sparing of the rectum would suggest Crohn's disease. As I've mentioned, ulcerative colitis begins in the rectum. Skip lesions are indicative of Crohn's disease. Stricturing much more common in Crohn's disease. Granulomas are only seen in Crohn's disease and not ulcerative colitis. Fistulization occurs in Crohn's and not colitis, and small bowel involvement as well indicates Crohn's disease. I'll just put this slide in for your own sort of perusal. I won't go through the extraintestinal manifestations of inflammatory bowel disease today. What do we know about the natural history of inflammatory bowel disease? Well, I think, like some of the other inflammatory bowel disease, such as rheumatoid arthritis, we now sort of recognise Crohn's disease as a progressive disease, in which small bowel damage or large bowel damage is cumulative. Patients may be well for a while with subclinical disease, but with each flare you accumulate more and more small bowel damage, which eventually leads to submucosal fibrosis, presence of stricturing, sometimes fistulae or abscesses. Ultimately, surgery may be required, and the process tends to occur again. Ulcerative colitis is slightly different in that the majority of patients will follow a relapsing and remitting course, whereby they have prolonged periods of remission, maybe intervening at times where they're unwell or have a disease flare. About 10% of patients will present with fulminant colitis and require hospitalisation and treatment, and a small percentage will have an intractable course where they just have chronic active symptoms. And the main complications we fear with ulcerative colitis are an episode of acute severe colitis, which I'll discuss a little bit later on, or the development of dysplasia or colorectal cancer. So if we turn our attention to the management of inflammatory bowel disease now, and I suppose when we're talking about treatment, we need to sort of talk about treatment goals. And in inflammatory bowel disease, these can be divided into short-term and long-term goals. In the short term, our aim is to induce remission, so make the patient feel better. But in the long term, the goal of therapy would be to maintain remission. So this is control of inflammation without needing steroids, and in doing so, hopefully preventing flares of disease, reducing complications and the need for hospitalisation and surgery, and by doing so, improving and maintaining quality of life. So we do have a number of treatments that are available to us, but certainly not an infinite number, and I'll go through these in turn just to give you some idea of what they are and where they fit in our treatment. So starting with sulfasalazine and the 5-aminosalicylates, and these include most commonly mesalazine in Australia, but also olsalazine and valsalazide. These are available in oral form through tablets, capsules or granules, or can be given rectally through suppositories or enemas for patients with distal disease. Like a lot of the drugs we use in inflammatory bowel disease, it's not really clear how they work, but they're generally well tolerated other than a few idiosyncratic side effects. Compliance tends to be an issue, particularly in patients who are taking these drugs to maintain remission because they're well and often don't realise the need for ongoing therapy. But compliance can be improved now that we recognise that once daily dosing is as effective as split dosing, which is how we used to use these drugs. So the main role for sulfasalazine and the aminosalicylates is in treating mild to moderate ulcerative colitis, both to induce and to maintain remission. We often use rectal therapy for patients with distal disease, so proctitis or proctosigmoiditis, but often use a combination of oral and rectal therapy for more extensive disease. There is evidence to suggest that these drugs actually reduce the risk of colorectal cancer in patients with ulcerative colitis, and it's not clear if this is purely because of due to control of inflammation or whether there's some other chemopreventative property of the drugs themselves. There's not a lot of data to support their use in Crohn's disease, and they've fallen out of favour a little bit in treating Crohn's disease, albeit they are used not uncommonly in patients with mild colonic Crohn's. There really isn't any established role for using antibiotics in uncomplicated colitis and very limited evidence for efficacy in luminal Crohn's disease. However, there are some circumstances where antibiotics are helpful. For example, in patients with suspected abscess, patients with perianal disease, such as abscesses or fistulae, and post-ileocolic resection. In ulcerative colitis, we tend to reserve the use of antibiotics for patients who develop pouchitis as a complication of pouch surgery. Corticosteroids are very effective in inducing remission, both in Crohn's disease and ulcerative colitis. So they're used to treat flares, and you can see good responses here after therapy. The problem is if you follow these patients out to a year after following a course of steroids for a disease flare, you see that only about a third to a half have had a prolonged response. About a quarter have remained steroid dependent, and about a third have actually proceeded to surgery. So it's quite clear that steroids don't maintain remission in inflammatory bowel disease, nor should they be used given the number of adverse effects that we are aware of with long-term steroid therapy. Budesonide is an alternative steroid, an alternative to traditional corticosteroids, and there are two types that we have available. Budesonide in the form of Entocort undergoes an extensive first-pass metabolism, so it's delivered specifically to the distal ileum and proximal colon, which makes it quite an attractive option for patients with limited ileocecal Crohn's disease. And more recently, we have budesonide with an additional matrix attached, traded as Cortiment, which resists degradation in the small bowel and is delivered to the colon, so makes it an attractive option for patients with ulcerative colitis or colonic Crohn's disease. So compared to conventional steroids, because of the lack of absorption, they have less side effects, but unfortunately neither of these drugs are available on the PBS, so they are available in a private script but at a cost to the patient. The thiopurines, namely azathioprine and 6-mercaptopurine, are prodrugs that undergo a fairly complicated metabolic process, which I've simplified here, to lead to the development or formation of 6-thioguanines, which are the active metabolite of these drugs, which reduce inflammation by inhibition of purine synthesis, T and B cell proliferation, and induction of T cell apoptosis. So there's good evidence to suggest that thiopurines are able to maintain steroid-free remission, both in ulcerative colitis or Crohn's disease. The downside is that they have quite a slow onset of action. It can take around 3 months for the effect of these drugs to be seen, so they're not particularly useful for inducing remission. So it might be in a patient that has a flare who's started on steroids, you might consider starting a thiopurine at the same time to maintain remission once the steroid course has been weaned. Dosing is in the order of about 2 to 2.5 milligrams per kilogram for azathioprine, slightly less for mercaptopurine, but dosing can vary between individuals, and some of this is based on differences in TPMT activity. TPMT is an enzyme, thiopurine methyltransferase, which you can see plays a part in metabolism of azathioprine and mercaptopurine, and largely determines the formation of these 6-thioguanine metabolites, which are the active metabolites, as opposed to 6-methylmercaptopurine or 6-MMPR, which are inactive or potentially toxic metabolites. So there are some polymorphisms in this TPMT gene which can be measured, and these polymorphisms can lead patients to risk of severe neutropenia if they overproduce 6-thioguanines. So if these aren't routinely tested, these polymorphisms, but they can be, and if they're available and a patient is a carrier, then dose reduction is important. We also have the ability to measure the 6-thioguanine and the 6-methylmercaptopurine metabolites, and this can be helpful in patients, particularly those who are not showing an adequate response to treatment. So, for example, in a patient who has absent levels of these metabolites, it's clear that they're not taking their medication, and they can be educated about compliance or adherence. Patients who have slightly subtherapeutic levels or low levels of both metabolites may just be underdosed, and it might simply be a matter of increasing their dose. Whereas patients who have high or therapeutic levels of these drugs, if they're still failing, I guess that indicates that the drug is ineffective and it probably is time to move on to a drug from a different class. But the interesting group of patients are patients who have low levels of 6-thioguanine but high levels of 6-methylmercaptopurine. So these are so-called shunters, and this affects probably between 10 to 20% of patients taking these drugs. And it's been identified that if you add allopurinol, which is a xanthine oxidase inhibitor, and you can see xanthine oxidase down here in this metabolic pathway, the addition of allopurinol can actually overcome and reverse this shunt, so that more 6-thioguanine, or the active ingredient or active metabolite, is formed rather than 6-methylmercaptopurine. And there is evidence to suggest that doing this works. So this is one of the initial studies that show that a group of patients who were identified as being shunters were started on allopurinol, had their thiopurine dose reduced as is necessary, and the outcome was that thioguanine levels were significantly increased, 6-MMP levels fell, clinical disease activity was reduced, so was the need for steroids, and liver function test abnormalities improved as well. So this isn't for everyone. There is some risk involved, particularly given the possibility that we overshoot the mark and we lead to excessive levels of 6-thioguanine, which can lead to myelotoxicity. So patients do need to have their thiopurine reduced to about 25 to 50% of their starting dose, and they need to be monitored very carefully with frequent blood tests, particularly in the first month. And then you can repeat the metabolite levels after about 4 weeks and see if we're in the right range and titrate the dose as necessary. So apart from myelotoxicity, there are other adverse effects which probably need to be considered for patients who are on thiopurines. Perhaps the commonest reason why they're stopped is because of some idiosyncratic allergic type reactions like fever, rash and arthralgia, as well as nausea. I've mentioned leukopenia and hepatitis. Pancreatitis is not an insignificant and not an extremely rare side effect. And of course, with immune modifying therapy, we need to be aware of potential for opportunistic infections. And in thiopurine use, there is an increased risk of lymphoma as well as non-melanoma skin cancer. Methotrexate, you'll know as a folic acid analogue. Again, not quite clear how it works in inflammatory bowel disease. It can be given orally, intramuscularly or subcutaneously, but the only randomised trial that showed any efficacy was in Crohn's disease, where it was given by an intramuscular injection once a week, and that was shown to be effective in inducing and maintaining remission. There's less efficacy data for the use of methotrexate in ulcerative colitis. You'll probably hear a bit more about methotrexate, particularly in your rheumatoid or psoriasis lectures, but the toxicities, the main ones we get concerned about are hepatotoxicity and myelotoxicity again, and also to note that methotrexate is teratogenic and shouldn't be used in patients considering pregnancy, and given these are diseases that commonly affect young people, may be of relevance. Cyclosporin is a calcineurin antagonist, inhibits cell-mediated immunity. It has a role in inflammatory bowel disease in the patient with ulcerative colitis who's admitted with acute severe colitis and is failing steroids, so may be heading to colectomy. That's where cyclosporin can be offered as a salvage therapy to try and regain remission and avoid colectomy, usually as a bridge before something like azathioprine or an alternative maintenance medication is started and kicks in. So it's not used for long term, it's not used in Crohn's disease, and part of that is related to its potential toxicities as well as potential for drug interactions. The drugs now that have probably revolutionised the way we treat inflammatory bowel disease are the anti-tumour necrosis factor alpha antibodies, namely infliximab and adalimumab, which we have in Australia, and there is a great wealth of data both in randomised trials and in real-world post-marketing data that demonstrate its efficacy in induction and maintenance of remission, in achieving mucosal healing and reducing complications. And I've just listed some of the registration studies that showed that these drugs were effective, but I'm not going to go through any data with you because we'll be here all night. So infliximab is the originator of infliximab was Remicade. There are now 1 or 2 biosimilars that have recently come on the market. This infliximab is given as an intravenous infusion, 3 doses over 6 weeks as a loading, and then every 8 weeks. Adalimumab is also an anti-TNF agent available as Humira, which is given via a subcutaneous injection every fortnight. And these drugs are now listed in Australia for treating moderate to severe Crohn's disease refractory to standard therapies, including steroids and an immunomodulator. They're used for fistulizing Crohn's disease. Infliximab, but not Humira, is available for acute severe colitis as an alternative perhaps to cyclosporin in the patient who's in hospital failing steroids. And we now have both of these agents also available for treating moderate to severe chronic ulcerative colitis failing standard therapies. In terms of adverse effects of anti-TNF therapy, probably the most common one is infusion or injection site reactions, and possibly a loss of response to therapy because of immunogenicity and the formation of anti-drug antibodies, which I'll mention again in a second. There are concerns about potential for opportunistic infections, and the one we fear and screen for is tuberculosis. And again, there are certain types of theoretical risk of malignancy, although this hasn't really come out in most of the available data, although again there is an increased risk potentially of lymphoma. So we have the ability to measure drug levels of our anti-TNF agent, and also measure for the presence of anti-drug antibodies. This isn't sort of used in routine practice, but is gaining traction. So for patients who are losing response to anti-TNF therapy, we can measure drug levels in the presence of anti-drug antibodies. The currently available assays, however, do limit our ability to detect antibodies in the presence of any detectable drug. So if you have detectable or therapeutic drug levels, you're probably getting the most out of your drug, and it's probably time to switch out of class and use something else. If you have low drug levels, you might be able to check for anti-drug antibodies, and if they're absent, you might just need to dose escalate, and that could be by either increasing the actual dose or reducing the interval between doses. But if anti-drug antibodies are present, you might have the option just to switch to an alternative anti-TNF, so go from infliximab to Humira or vice versa. A drug that's recently become available both for Crohn's disease and ulcerative colitis is vedolizumab. This has a different mechanism of action. This binds the alpha-4 beta-7 integrin on T lymphocytes and blocks its interaction with NADCAM, which is a cell adhesion molecule found on the intestinal endothelium. So this drug blocks trafficking of leukocytes to the gut, so it has a gut-specific action, making it sort of theoretically more attractive in that it doesn't have the systemic risk or side effects of some of the other immune-modifying therapies. So it has a very good safety profile, and as I said, is currently approved for use for treating ulcerative colitis and Crohn's disease. The next drug that we'll probably have, it's actually been approved for use in Australia but not yet listed on the PBS, is ustekinumab or Stelara, which has been used for a little while now for treating psoriasis and psoriatic arthropathy. This is a monoclonal antibody against IL-12, IL-23. So this blocks its interaction with the receptor on the surface of antigen-presenting cells and natural killer cells. It blocks intracellular signalling and therefore the production of inflammatory cytokines such as TNF-alpha and the like. So this drug is given as a single intravenous infusion followed by 8 weekly subcutaneous injections, and should be available probably for use in Crohn's disease in the next 6 months. And there are a number of other drugs that are probably not too far away, but I won't go through those. So where do we position these medications when we're thinking about treatment for inflammatory bowel disease? I guess an effective sort of approach to therapy relies on clearly defining our treatment goals and then setting timeframes required to achieve these goals, recognising when treatment's ineffective and then escalating treatment in a timely manner. And our treatment goals have evolved from purely symptomatic improvement to looking at sort of remission of symptoms off steroids, and perhaps now in 2017 to trying to achieve deeper remission as evidenced by improvement in endoscopic findings and even histological remission as well. And we can probably achieve these goals better by being a bit more proactive in our treatment, using more effective therapies earlier on in the disease course, usually in combination. So just thinking about the natural history of Crohn's disease again, so the majority of patients will present early on in their disease with an inflammatory phenotype, but as time goes by will develop more stricturing or penetrating complications, which puts them at higher risk of needing surgery. So there might be this window of opportunity in the first few years after diagnosis of Crohn's disease, where the disease is still purely inflammatory, to use some of our anti-inflammatory medications to try and arrest some of the inflammation and change the natural history. And this was studied in a paper sort of named or known as the Step Up Top Down study, which was published in The Lancet almost 10 years ago now. And that study had a few methodological sort of provided this notion of more aggressive early therapy might be beneficial in treating Crohn's disease. So this took patients with fairly recently diagnosed Crohn's disease and treated them in what they said was in a conventional manner, whereby they had steroids up front, and if they flared again, they had more steroids, and if they flared again, they'd have azathioprine, and if they were still unwell, they would get infliximab, and compared that to a top-down group where patients had infliximab and azathioprine up front. They were only given 3 doses of infliximab, and then if they still became unwell, they had episodic infliximab on demand, and then maybe steroids if they were still unwell. And this study met its primary endpoint, which is the remission without the need for steroids or surgery at 6 months, which is significantly more likely to occur in patients who had early combined immunosuppression compared to those who received conventional top-up therapy. And mucosal healing rates were significantly higher in the patients who were treated aggressively from the outset. And a landmark study that was published in the New England Journal in 2010 was the SONIC study, which showed us that combination therapy was more effective than monotherapy. So this is a study of over 500 patients, again, who were naive to biological therapies or thiopurines early on in their disease course, who were randomised to receive either azathioprine alone in red, infliximab alone in yellow, or a combination of azathioprine and infliximab in blue. And their primary endpoint was steroid-free remission at 6 months, which was higher in infliximab-treated patients compared to azathioprine, but higher still in patients on a combination of both therapies. And this translated to an improvement in mucosal healing. And a similar study was published a few years later, which was the SUCCESS study. This was a similar study designed but in patients with ulcerative colitis. And again, you can see that patients receiving combination therapy did better in terms of clinical and endoscopic endpoints. But with this increase in efficacy may come an increase in risk using combined immunotherapy. And there's evidence to suggest that patients taking steroids or a thiopurine or infliximab have a higher risk of opportunistic infection. But if you're on a combination of 2 or 3 of these agents, then that risk is significantly increased. Although it's proposed that a lot of that risk does relate to the use of steroids, and we try and get patients off steroids as quickly as possible. I touched on the risk of lymphoma as well, and there is evidence to suggest that patients exposed to thiopurines with or without infliximab do have an increased risk of lymphoma over baseline, although it should be remembered that baseline risk is fairly rare, and the potential risk of these therapies obviously needs to be balanced against the potential benefit. There is a very rare but aggressive form of lymphoma called hepatosplenic T-cell lymphoma, and there have been a number of cases described in the IBD literature in patients on thiopurine therapy, about half of which had received infliximab as well. These were almost always in young males, and unfortunately this is a very aggressive type of lymphoma that was almost universally fatal as well. So this is a particular demographic in young males who we're slightly concerned about, although the risk is still extremely low. We probably will only treat them with combination therapy for 6 to 12 months and then try and reduce the burden of immunosuppression if they're doing well. So how do we approach sort of the treatment of Crohn's disease? Generally speaking, in someone who is sort of moderate to severe Crohn's disease, you would treat them with a course of steroids, and you'd be looking to start something like azathioprine or mercaptopurine at the same time, aiming for a steroid-free remission, so tapering the steroids and really hoping to achieve that in the first 3 to 6 months. And if that's so, you could continue on monotherapy. Whereas if you're unable to achieve those goals, then it's probably time to add in something like infliximab or adalimumab. And now we have the option in patients who don't respond or lose response to consider alternative treatments such as vedolizumab or ustekinumab. But how long do we treat for? And this is a question that we're commonly asked by patients, particularly if they're doing well, and there are concerns about possible long-term safety with these drugs, as well as other reasons for patients wishing to stop therapy. There was a study published recently called the STORY study, and this looked at patients who were doing well on a combination of infliximab and azathioprine. They were in clinical remission for at least 6 months, and their azathioprine was stopped. Their infliximab was stopped, and they were left on azathioprine. And the relapse rates were not insignificant at 39% within a year of infliximab withdrawal. The good news was that almost all relapses were able to regain remission once infliximab was recommenced. And what we did learn from this study was in a subgroup of patients who had a normal CRP and a normal colonoscopy, the risk of relapse was much lower, sort of further indicating that if you do have this sort of deep remission beyond purely clinical remission, then you're more likely to do better and be able to stop therapy. For ulcerative colitis, our treatment sort of depends more on the severity of the disease. So for mild disease, we usually use aminosalicylates both for induction and maintenance of remission. Steroids for flares or moderate disease, with aminosalicylates or thiopurines used to maintain remission. Anti-TNF or cyclosporin. Cyclosporin for acute severe episodes failing steroids. Anti-TNF we can now use for chronic active disease failing conventional therapy. And vedolizumab is another option as well. And obviously colectomy is still required in patients failing all treatments or with refractory colitis. So just a few special circumstances to mention before finishing off. Stricture in Crohn's disease. So strictures theoretically can be divided into inflammatory strictures, which will more likely respond to medical therapy, or fibrotic strictures, in which anti-inflammatories are less likely to work, which may require endoscopic dilatation or surgical intervention, although in reality most strictures probably have a combination of both elements, and it's very hard to differentiate between the two. Surgery for Crohn's disease is not uncommon. Early studies suggest that it might be in the range of 50 to 60% at 10 years, and the indications for surgery being failed medical therapy or development of complications. And the natural history of Crohn's disease is one of recurrence. So surgery is not curative in Crohn's disease. In fact, up to 80% of patients will have some form of endoscopic recurrence within the first year of surgery. In terms of preventing post-operative recurrence, there's some evidence for, not very good evidence, for aminosalicylates. We tend to use antibiotics for about 3 months post-operatively. Thiopurines show moderate benefit, but the drugs that probably work best in preventing post-operative recurrence are the anti-TNF agents. Just a word on fistulas in Crohn's disease. This is quite a morbid complication, but it affects around 25% of patients with Crohn's disease and is often associated with poorer outcomes. And it requires a combination of both medical and surgical approach to treatment, so the surgeons are involved in terms of identifying and draining any abscesses and possibly inserting cetons to allow adequate drainage of any perianal sepsis. And in terms of medical therapy, usually the treatment involves a combination of antibiotics, usually a thiopurine, and anti-TNF drugs are probably the most effective. So I'm whipping through this, we're just trying to get through it in time. Acute severe colitis is another important complication of ulcerative colitis. It's defined by the presence of bloody diarrhoea with at least one other systemic sort of toxicity, such as tachycardia, fever, anemia, or elevated ESR. These patients need hospital admission and treatment usually, with intravenous steroids as well as other supportive therapies, and surgical review as well in case they do progress and need colectomy. We usually sort of define response within 3 days, and if patients at day 3 are still having diarrhoea or an elevated CRP, they need some other form of salvage therapy, whether that be infliximab or cyclosporin, and in those patients who are failing, then colectomy may be required. There was a study that compared the use of cyclosporin and infliximab, and basically the bottom line was the two treatments were equally effective. So surgery for ulcerative colitis, again, is indicated in patients with fulminant disease or patients failing medical therapy, or obviously if dysplasia or cancer develops. So just a word on colorectal cancer and inflammatory bowel disease, where the risk is higher, and that risk is often associated with the extent and duration of disease as well as severity of inflammation. Presence of primary sclerosing cholangitis significantly increases the risk of colorectal cancer, and these patients require yearly endoscopic surveillance. And if you've got a family history of colorectal cancer or personal history of dysplasia, you're at increased risk. And the concern is that these malignancies tend to develop at a younger age and are associated with higher rates of mortality. So there are guidelines to suggest colonoscopic surveillance to try and detect dysplasia at an early stage prior to the development of colorectal cancer. When patients have surgery for ulcerative colitis, there is the option of performing a total proctocolectomy and then forming an ileoanal pouch with the distal ileum anastomosed to the anus. While this is sort of curative for their colitis, it doesn't restore normal bowel function, and it's quite normal for a pouch to be emptied 6 to 8 times a day. It's also important to know that there is reduced fertility because of the pelvic dissection that's required in forming a pouch and anastomosing it. So particularly in young females who haven't had their family, that's an important consideration. And pouches can be complicated by the development of pouchitis, which is usually treated with antibiotics or sometimes probiotics. Just some other management issues to touch on, and these are things that may well come up in long case discussion if you get a patient with inflammatory bowel disease, and something you probably need to know a little bit about. I've mentioned smoking is an important contributor to Crohn's disease. Obviously, smoking cessation is important, particularly for patients with Crohn's. Nutritional assessment and nutrition is important, particularly screening for things like iron deficiency, B12 deficiency, vitamin D deficiency. Osteoporosis can occur because of the chronic inflammation associated with these diseases, but also because of steroid exposure. Psychological well-being is also an important consideration. These are often young patients who may need time off work, time off school. There are social stigma associated with this disease, intimacy issues, problems with stomas, etc. So it's very important to assess the psychological well-being of patients as well. I haven't spoken about vaccination, but there are some preventable things that should be considered for patients who are on immune-modifying therapies, so that these patients are recommended to have flu vaccine, pneumococcal vaccine and other vaccinations, bearing in mind that the varicella-zoster vaccine is a live vaccine, so it shouldn't be given to patients on immune-modifying therapy. Cancer prevention is important. I've mentioned non-melanoma skin cancer, so patients on thiopurines and biologics should have regular skin checks. There's some evidence to suggest an increased risk of cervical neoplasia, so pap smears are important, and I've spoken about colonoscopy. And just a slide on pregnancy and inflammatory bowel disease, just a couple of take-home messages just to note that there is an increased risk of adverse outcomes associated with active inflammatory bowel disease, things like low birth weights and preterm births, for example. There is some conflicting data about rates of congenital abnormalities, although it's likely that these aren't increased. Most medications are safe in pregnancy. We don't use methotrexate, as I've mentioned. This is contraindicated. We tend to stop the biological therapies such as infliximab and adalimumab in the third trimester, where they cross the placenta and are found in fetal blood. There's really limited data about some of the newer agents like vedolizumab. We just don't have enough experience. But I think the important message is that the best outcomes are achieved if remission can be achieved prior to conception and during pregnancy. So usually the safest thing would be to continue medication and keep the patient well. So just to summarise then, the inflammatory bowel disease is an important condition. The incidence is increasing. It affects young patients and has high morbidity. We're learning more about its pathogenesis and the genetic, the immunological and the environmental contributors to disease. There is still no established cure for inflammatory bowel disease, but there are an increasing number of effective therapies that do require a personalised approach with careful monitoring of the individual to minimise risk. And I think our aim for treating patients is to maintain a steroid-free remission, and if there's inadequate disease control, to optimise therapy. So I'm going to stop there, and I'm happy to take any questions in the next minute or two.
Okay, we'll begin with any questions from the local crowd here. Otherwise, and I know there's nobody at the sites, but please thank our speaker, Dr. Mark Lusk.
Thank you.